Welcome to the Valaura Exchange, where leaders connect the dots between health, humanity, and performance. Each episode brings real conversations, fresh perspectives, and the insights shaping the future of how healthcare leaders understand and solve today's most pressing challenges.
Medicare Advantage continues to evolve, and the 2027 Final Rule and rate announcement introduces meaningful changes that plans are going to have to respond to quickly. A lot of the industry conversation focuses on the policy itself, what changed and what didn't. But today, we're focusing on how these changes translate into day-to-day operations, financial performance, and most importantly, star ratings. Because at the end of the day, that's where plans really feel the impact. For those of you tuning in for the first time, I'm Teresa Connolly, Director of Clinical Business Development at Valaura.
And I'm Ifam Ahmed, Chief Clinical Officer at Valaura. And what really matters is how these policy changes show up operationally, how they affect member engagement, our care plans, and overall star performance in the plan. So these are some of the things that we're going to talk about today. We're really excited. We have a wonderful guest on to talk to you all about all that today.
And to help us unpack this more today, we have Jessica on the line. Jessica, we're really glad to have you here. Just before we dive into the questions that we have prepared for you today, would you mind giving us just a quick overview of your background and also what you're focused on today?
Sure. Thanks, Teresa. Thanks, Ifam, for having me. I'm really excited to be here and talk about this topic. So I'm Jessica Muratore. I own Muratore Advisory Services. I'm the founder and senior consultant, principal consultant. Prior to moving to consulting, I spent over a decade on the health plan side. So I worked for a small regional and then a national plan in executive roles, primarily on the quality improvement side for Medicare, Medicaid, Marketplace, commercial FEP business, and really focused on star ratings or quality improvement, performance improvement across the enterprise.
Awesome. Thank you for that context. It's really helpful, and it sets the stage for the conversation today because of all the knowledge that you have from your past history, but also with what you've been learning and continuing to iterate on with all the new CMS rulings that are coming out as the year evolves. So to start us off, for the first question, I wanted to ask you, when you look at the coverage year 27 final rate and rule announcement, what do you see as the biggest implications for star ratings performance?
Yeah, this year, it was pretty significant compared to other years, but I think first and most obvious, the removal of 11 measures, including the entire administrative measure domain. This domain, the appeals measures, the call center TTY foreign language interpreter, members choosing leave the plan. So this domain, it's the highest performing domain in star ratings. And on average, it's performing at, 4 stars or better. Truly, this domain and the measures in it have become table stakes for health plans, with those performing lower being the outlier. And so what this means with the removal of these measures is that the plans are losing measures that were more solely within their control, right? And this places more weight on clinical outcomes, medication adherence, member experience, costs. All of these are within the control of a plan, but a lot harder to influence without deeper operational alignment. And I think something important to understand is why CMS did this. And they said that the consistently high performance and limited differentiation across contracts indicate that these measures no longer function effectively as star ratings quality measures. And so by reducing the number of measures pretty significantly, it would increase the focus of the measure set for star ratings on clinical care, outcomes, and member experience measures. We also saw the addition of the depression screening and follow-up measure, the DSFE measure, which CMS said themselves fills an important behavioral health gap in star ratings. And this is a clear signal that CMS, at least with this administration, intends to integrate behavioral health into star ratings. This is the first of probably many, and we should take a look at the display measures and the performance on those measures as an indicator of what else is to come. And specifically, I would call out for plans the IET and FUH measures that are on display. And I think lastly, Teresa, we saw the removal of the health equity index in favor of the heavily lobbied reward factor. Even though the Health Equity Index was codified through rulemaking and in place for all of measurement year 25 or STARS 27, CMS told us that instead of incentivizing improvement amongst certain populations, like the Health Equity Index was intending to do, they would instead incentivize payment efforts or improvement efforts focused on clinical care and outcomes and experience to refocus Medicare star ratings measure set. They also use this as an offset to the impact of the removal of the 11 measures that would have an overall decrease in ratings. Although it's no surprise that this administration did get rid of the Health Equity Index, I was surprised that they didn't do it last year, and furthermore surprised that they could do it the way they did retroactively via an executive order. So I think overall, these are the biggest implications for star ratings directly.
Thank you very much. I agree with you too, and I will continue to stay tuned because we know that things can continue to change as the administration makes more choices. So thank you.
Yeah, thanks, Jessica. That was a wonderful breakdown of the policy changes. And just to build on that a little bit, when you start to translate those changes into execution, how do these changes affect how plans need to operate day to day to maintain or improve their STARS performance?
That is a great question. It's something that I am having conversations with on a daily basis with health plans and vendors supporting health plans. So the 2027 final rule doesn't simply just reduce the number of measures. It's now intensified the star ratings program. Star ratings have become more concentrated and a higher risk program, frankly. There's less buffering for plans, which means more exposure to single measure movement. So as a result, to be successful, these changes fundamentally shift star rating strategy from oftentimes seasonal campaign-based efforts to ideally a daily operating discipline. And this is where I spend a lot of time educating plans. Plans can't rely on year-end pushes or administrative measure buffers anymore. They have to manage performance in real time. And this means embedding stars into day-to-day operations. Every member interaction, whether it's care management, pharmacy, provider visits, they need to be an opportunity to close gaps and build trust. And in stars, I've spent so much time in my career on the healthcare side saying this, but stars isn't owned by one team, it's cross-functional. And I understand this and always have, but now these changes will really force health plans to build into this, build it into their operations and their governance, or they're really going to struggle now. I think second, plans need to operate with a much stronger performance management cadence. This includes weekly or maybe even daily visibility into performance metrics, rapid escalation of issues, very clear accountability. You're essentially running stars like a production system and not a reporting function anymore, inclusive of all departments, not just the quality or stars department. And then I think third, there's a bigger emphasis on targeting and precision. And you guys know this really well, Laura. With fewer margin of error measures, plans need to focus on the right members at the right time, and especially focus on those high risk, hard to engage populations that drive both outcomes and experience. I think provider and member engagement models, they have to evolve now. It's less about outbound campaigns. It's more about longitudinal relationships, making it easier for members to navigate care and for providers to close gaps at the point of care. So health plans need to be the orchestrators of all of this.
I absolutely agree with you on that. And we see that all the time, just what you were mentioning about making sure that you're doing the targeting very precisely, but also being agile, like moving quickly and trying to be as updated as possible, like you were saying too. It's 100% correct. We handle that all the time, and we also agree that it's very important to make sure that we're on task, on cue, and also collaborating across all the different areas, because that's huge to be able to achieve all these goals. So thank you again. Another theme that we're hearing more and more right now is that plans are under pressure from cost, compliance, also performance all at once. So it's all coming at them, bombarding them. I know there's a lot going on. So thinking about that balance, how should plans think about balancing those three factors and STARS performance in light of all of these updates that are coming through the final rule and final rate announcement?
Yeah, this is a very real consideration for plans. So I guess like the winning approach or strategy is not, it's no longer balancing trade-offs. You have to align cost and compliance and STARS performance into one coordinated strategy where the same actions improve quality and reduce cost and stand up to like that audit scrutiny. Plans can't treat them as competing priorities because these changes are truly pushing towards a single integrated performance model. First, STARS is a cost strategy. High performance and medication adherence and preventative care and coordinated care directly reduces avoidable utilization, ED visits, admissions, and readmissions. And so the question isn't what does STARS cost? What's at risk for us? It's how does STARS reduce the total cost of care? Second, from a compliance perspective, compliance and STARS are converging around data discipline. The same infrastructure that ensures audit readiness, clean data, clear documentation, traceability, that's also driving better star ratings performance. So investments in governance and data quality serve both. And I think third, plans need to be getting much sharper on prioritization and ROI. Not every measure, you guys know this really well, not every measure delivers equal value. High performing plans, they know they cannot boil the ocean. They focus on high impact measures that are tied to both revenue and utilization. High risk members who drive both cost, inclusive of risk adjustment, right? And STARS outcomes. And then interventions that scale efficiently, right? Across lines of business and work into provider workflows and that can have more targeted engagement. And I think finally, this is so important, it's said so often, but it's harder to put it in practice and really execute on it. But this requires cross-functional alignment, finance, compliance, quality, pharmacy, network, marketing, IT. They all need to operate off of the same priorities and same goals. And fragmentation is where costs increases and performance drops.
Oh, thank you, Jessica. You mentioned something that kind of leads into my next question, that cross-functional alignment. I know you know this very well, and this is very important for our viewers as well. One important topic and relationship that I want to focus on is this relationship now between risk adjustment and quality. So, from your perspective, how do you see this relationship between the two evolving under the 2027 changes?
Yeah, I love that question, Ifam, because all too often, I've worked in parts of risk adjustment mainly from the quality lens, right? But I see risk adjustment and quality being treated as separate teams or departments, and that is definitely a mistake. There are so many operational synergies that exist between them, and I've had, the benefit of working alongside a lot of really smart risk adjustment folks that taught me a lot. But over the past few years, particularly under the 2027 changes, though, the relationship between risk adjustment and STARS is now becoming more integrated and more interdependent on one another. Risk adjustment is no longer just a revenue production tool, very important, but it's evolving into a targeting mechanism that helps plans identify high risk members who also drive quality performance. So as a result, successful plans will be aligning coding and already do clinical care and quality initiatives so that the same member interactions support both accurate risk capture and care gap closure. And this convergence combined with, the increased audit scrutiny that we're seeing with these changes, it means that data accuracy and provider engagement and member outreach absolutely have to be tightly coordinated. And this includes sharing of data. So ultimately, the plans that treat risk adjustment and STARS as a unified performance strategy rather than separate functions and separate departments, they're already and will be best positioned to improve outcomes and maximize their financial impact and quality performance. And that isn't just for clinical measure care gap closure adherence either. Member experience becomes the bridge here. High risk members with high RAF scores, they are more complex, they're harder to engage. they're more likely to impact caps and utilization negatively. And so the plans that align risk stratification with high touch engagement models are absolutely going to outperform. And then STARS drives the bonus payments and the rebate percentages, and risk adjustment drives base revenue. So the same members will increasingly drive both. So when you have poor alignment between STARS and risk adjustment, that is absolutely a recipe for missed revenue on both fronts.
No, that's absolutely correct. And another thing to keep in mind, like adding to what you're saying, is also thinking of the member perspective, right? We'll have a better experience overall, like you were saying, bridging that gap if we can keep everything kind of together, right? Making a flow, making it make sense, making the patient feel like they're part of their care, not just being bombarded with a bunch of outreaches, because the intelligence behind the health plan is making sense of all of those things that you just kind of iterated and listed. So very, very accurate. And I appreciate that feedback. So as plans are thinking about all of this in real time, because there's a lot going on, bringing it down to what they should actually be doing next. What are you advising Medicare Advantage plan leadership teams today for the top 2 to 3, let's say, things that they should be doing now to prepare, especially from a STARS and then also a performance perspective?
I am constantly advising Medicare Advantage leadership teams and executives. I focus primarily on 3 things overall. First, the operationalizing STARS as a daily management system. It's not just a seasonal initiative, a Q4 push. We've all heard, quality is not just a department, it's a culture. Well, that culture of quality, or the culture of STARS, it means real-time performance visibility and clear ownership at the measure level and consistent cadence for escalation and action. I can't emphasize this enough. STARS should show up in weekly operational reviews and not just year-end reporting and Q4 pushes. Another thing is to get much more precise in targeting and engagement. The margin for error is gone. Plans need to identify the right members and the right providers that are driving performance, especially high-risk, hard-to-engage populations. I can't emphasize this enough. Deploying a more personalized, longitudinal engagement strategy rather than broad campaigns, like throwing spaghetti against the wall, right, and seeing what sticks. And oftentimes you do need to rely on vendors for this, the right vendors to do this. And I think third, invest in data integrity and integration. Clean, timely, defensible data is now table stakes for plans. It's not just for performance, but it's for audit readiness now and compliance. Plans need aligned data pipelines across HEDIS and pharmacy and care management and provider engagement for provider reporting. So everyone's operating off of the same source of truth. I can't even tell you how many times I've worked with plans where, there's different care gap closure lists floating around for the same measures because they're coming out of different sources of truth. And the plans that win will be the ones that combine that disciplined execution with precise targeting and trusted data, the source of truth. And they embed all 3 into how they operate every single day. And I think those are the 3 big areas that I focus on when talking to leadership.
Awesome. No, completely agree there. And also just having executive presence, like you were mentioning, the fact that we need to make sure that this is not just we're going to do a push here and there. We have the executive folks on board to push that need for metrics, whether it be daily or weekly, like you were saying, huge, so that the plans can stay ahead of things and be more proactive rather than reactive. So thank you for all those thoughts. It's very helpful. So to close this out and just taking a step a little bit back from all of this that we've discussed today, what's one more thing that you would advise health plan leaders, or I should say you wish health plan leaders would understand more about how these policy changes will impact STARS and also their overall performance, so we give them some good takeaways?
Yeah, absolutely. Health plan leaders need to understand that governance is the mechanism that turns quality as a culture from a motto or a saying or a slogan into like an actual operating model. It's that backbone. Setting quality goals of 4 stars across the health plan doesn't cut it. I've been been there before. Without cross-functional structure that sets expectations and aligns incentives and embeds quality into daily decision-making, the health plan inevitably defaults back to treating quality as a department, and they're the ones that own the work. And so a strong governance model makes quality everyone's job, ensures accountability lives at the right levels, and it creates the transparency, kind of this rhythm needed for continuous quality improvement, rather than what we often see, these episodic end of the year pushes and scrambling because the rates aren't where we expected them to be or where we need them to be. I think variation is the new currency, and CMS is designing the program to expose that now with these changes. They're intentionally selecting measures with wide performance variation. I mean, they said that, and that's aligned with why one of the reasons star ratings is put in place. So what that means is like plans can't hide in the middle anymore. The spread between that 3.5 and 4-star performance is definitely going to widen. Outlier performance, both good and bad, will matter more than ever. So leaders have to understand that stars is becoming a competitive outcomes program. You can no longer optimize your way to 4 stars. You absolutely have to start performing.
Thank you, Jessica. And I just wanted to say, in general, this was such a great conversation. I was really excited for it. We're lucky enough we get to talk to you regularly about this. So for you taking the time for our viewers to talk through this was huge. You know, for me, a big takeaway is these just aren't policy changes, but these are operational changes. And the plans that will win out, like you say, are the ones that take that policy but then execute into operational changes. So very important topic. And for those listening, if they want to get more information or more in touch with some of the things that you put out, what would be the best way to reach you or get more information?
Yeah, you can reach out to me directly for sure. You can reach out to Teresa or Itham and get my contact information, or we can post it out, on the podcast.
Wonderful. And your LinkedIn is a great place. You put a lot of the content out there as well, right?
Yep, definitely leverage LinkedIn for sure.
Thank you again, Jessica, for joining us. I really do think this is a big gap for a lot of organizations, but stuff like our discussions and all the other discussions that are surfacing, that's really what's going to help make the change, drive the change, and hopefully drive to success for the plans of what outcomes they're looking for to achieve. From our perspective at Valaura Health, especially around improving stars and member engagement, that's really where we're seeing the biggest opportunity. So just again, thank you for your time, Jessica, and we really appreciate your perspective. And for everyone else that's listening out there, thank you for taking the time to be with us, and we look forward to chatting with you soon. Hope you have a great day. Thank you.